seemingly conflicting recommendations. I think that would be helpful, so just leave that. And the second thing I wanted to say was just a perspective on something that hasn't been brought up is demographics. The cardiovascular disease, at least mortality, is concentrated in the 65 plus age group. 1 in 6 is in the 45 to 65 age group. But that age group, the general population has grown about 3.5% in the last 5 years. The 65 plus age group has grown 19%. And it's expected to grow another 50% nearly between 2016 and 2030. So that any way that we do anything, we can anticipate there's going to be a significantly greater burden of disease, of heart disease at least in general, which is not all uniform certainly, but overall heart disease mortality has not been declining. It's nearly stagnated over the last 5 or 6 years, the rate of decline. So that's something in general considerations, because whatever gets done is going to get magnified unless something happens dramatically by 20 over the upcoming years. And one thing we didn't discuss, but probably should have in the back of our mind, which is heart failure, which is going up greatly. It's probably related to the fact that we can save more people and prevent more heart attacks or have less serious heart attacks. But heart disease mortality has increased. The rate has increased 20% in the last 5 years. If you put that together with the other stat, you could see a doubling of that. Right now, if it was by itself, it'd be the 8th leading cause of mortality. I think there's supposed to be about 8 million cases in the country, and that's going to go to up.
It's really hard to hear you. If you could bring the mic closer, and could you just talk about what you're seeing in your cardio study related to heart failure and coronary calcium?
Well, we don't have enough heart failure to really comment on it. I was making a general comment on it because I think it's relevant to all the work that's being done here. Now, in terms of Kaiser, and I should slap myself if I say Kaiser without saying Kaiser Permanente. But Kaiser Permanente, I've spoken with cardiology colleagues, and there's no really guidelines for the use of CT, coronary calcium scans in Kaiser Permanente. What Kaiser Permanente has done is had pretty aggressive statin and other medication programs for people with any manifestation of cardiovascular disease, with diabetes, chronic kidney failure, etc. And they've also been very aggressive on hypertension. So what you see is pretty low rates of cardiovascular disease mortality compared to the nation, which is not surprising. But the one thing that I think is very relevant in our discussion today is that we published a paper recently which we compared the declines in cardiovascular disease rates over the past 15 years in Kaiser Permanente, Northern California, with national rates. And over the age of 65, the declines were pretty good, and they were about the same, about 35% or so. Under the age of 65, the rates of decline in Kaiser Permanente were over twice as great as in the national population. And my suspicion is that it's a greater problem than either the CT scans, and I do agree. I agree with the AHA guidelines on those, but the suspicion is that those people are not identified, and if identified, it's not taken as seriously overall. So I think as we talk about the strategies here, that's very important. But I don't really have anything to add on the CT scans except to say I can't really tell you what our Kaiser Permanente data is, just to say that there's no general guidelines on its use. There are specific guidelines on using medications when you think somebody's got any manifestation of disease.
So, Dr. Sidney, I think some people may be confused about where your Cardia data is coming from. It's a big national trial.
Cardia is a national study funded by the National Heart, Lung and Blood Institute, NHLBI. It has 4 centers around the country. It started in 1985. And we have one of these centers, one of the field centers at Oakland. And all of our cohort members were originally Kaiser Permanente members, and now it's down to about 40%. So it's really not, a Kaiser Permanente study at all. But those findings, which I said, they totally reflect what Matt was saying, just at a little bit younger age.
So I have a big picture question, and we'll start with you to respond, Steve, if we may. And that is a call to scientific action, to say that where we have this precision information, precision medicine around clarity for which patients have atherosclerosis. We now know they have it. And what Doug was saying is, well, we don't necessarily know what to do about it and whether we can change the outcome. So my scientific question to all of you is, shouldn't we be looking back at all of our large data sets, looking internationally what has worked? If none of that is telling us what does work, then what is the scientific agenda to figure out what will work, given this is the #1 killer?
I'm not knowledgeable enough to know about, all the clinical trials that might, have been done that are relevant to this, or the observational data. Certainly in cardio, we don't, at age 33 to 40, back in the time they were that age, statin use wasn't that widespread, so we can't address it from there. I think probably if they have the right, data collection, some of the observational studies might be able to do that. I don't know if that's possible in MESA. I don't know if MESA is, set up in a way where you could, address questions, like that. And certainly there's a number of other studies. I think it would be feasible to do a, clinical trial, in a place like, Kaiser Permanente, for example. You could randomize different medical centers, but it would take a whole bunch of money. It's not cheap.
Or we can do what we've done, for instance, with breast cancer, which is say once you identify a woman with breast cancer, you throw everything you have at it and hope that she survives.
Well, that's basically, kind of the approach in Kaiser, where you be given, statins, beta blockers if they had, heart disease and, some of the other medications.
I have a question to that though. How do you identify that they have heart disease without looking inside of the arteries?
Well, that's something that we, as a system, could, very well miss, because we don't do the scanning on the regular. No, I'm saying that, but we do have fantastically low, we've had driven disease rates down dramatically.
But how do you know that you've driven it down if you haven't looked inside the arteries?
We've driven it down because we measure disease rates of heart attacks. It doesn't mean that we've gotten everybody, but through this system of putting high-risk people on these medications, we drove ST elevation, the worst kinds of MIs, down by more than 50% in 10 years, and another 20-25% over the next several years. So that's clear.
But were they identified based upon their biomarkers and their blood pressure and their cholesterol?
Yeah, blood pressure, if they had, diabetes, for example, all of those people, and those people should be on statins. I don't recall all the conditions that they would have. They have aortic, peripheral artery disease. If they have manifestations of coronary disease, it might be by, you may not have seen the CT, they may not have an angiogram, or they may, but they just don't, we don't, as a matter of practice, have guidelines on use of the CT scans, and I cannot tell you how, how often they're used. That's something I'm not sure that has been looked at, and I certainly don't have that information. I just know there's no guideline, and maybe these new AHA guidelines will change it. But
I think
some
Dr.
people,
Sky had,
yeah.
after you, Steve.
yeah, no, I think I should probably conclude here, unless there's any questions. I've taken up a lot of air here.
Well, I think the point you're trying to make is that even with those successes that Kaiser Permanente has had, most of us would still make the point that the unacceptable rates of cardiovascular disease, even within a system that has a great primary and secondary prevention program, are still too high. Would that probably be fair?
But also the Kaiser may be over-treating a segment of the population that don't need it.
So there's room for improvement.
Well, I think there's room for more precision.
Yeah.
I would say that.
Yeah, there's room for.
Just a quick response, then we probably need to wrap up. But you can ask the question, and this gets at this issue of what sorts of studies, and Hattie suggested, well, we need just more reanalysis of observational studies. And I wanted to get back to the pitch that we really need more randomized clinical trials. So when the task force gives an I, insufficient evidence rating, that actually helps tee up what the agency should be thinking about in terms of their funding portfolios. And PCORI now watches what the task force does and others. But one of the reasons I think it's so important to get back to randomized clinical trials is that when I worked for the NIH, we had the opportunity to go back and reanalyze data from all the big NHLBI trials over the last 50 years. And what happened was that after the year 2000, there was a big shift. So positive trials were fairly common before 2000. After 2000, they became very rare. And that partly that's because that the standards for reporting really changed. So transparency really changed. A lot of other, trials had to be pre-registered in clinicaltrials.gov and so forth. That really changed the likelihood that a trial was produced a significant result. So if you ask this question, well, how often did promising results from observational trials get confirmed by randomized clinical trials according to these NHLBI trials? And the answer is almost never. And so again, it just raises this issue that we need to use what we believe to be the very best methodologies for estimating coverage.
But in the meanwhile, the clinical community has to have a path forward. So we have really strong data on the power of statins, on the power of this new prescription fish oil, on what are they, SGLT2 inhibitors, I'm the wrong person to be saying, but there are some really powerful new guns in the holster. And right now, we have a tool to identify more vulnerable patients. And even if we don't prospectively go out and scan more patients, which I think we should do, and do our best for them, we certainly have a lot of incidental findings in the medical records. And I emailed our military guys today to say, why don't we look back at all those positive CT scans and seek out those people who had a positive score and make sure they're on preventive therapy? Because at least the observational data indicates that, Dr. Budoff, we have a 40% lower incidence of serious cardiovascular events if people are put on statins and aspirin. Did I get that right?
Yeah, in MESA, it's about 40% reduction if they're on statins. So we looked at patients who are longitudinally over 10 years, taking statins, not taking statins, not randomized, but 7,000 people observational studies. And I would disagree a little bit. I would say the concordance between observational studies and outcome studies is high. It's not perfect, but it's very high. And I think Doug would probably support that, or else every time he comes up with an A based on observational data, you'd be implying that he's completely wrong. And I don't think that's, I don't know, you misstated or if I misheard, but I thought you said it never correlates.
No, it's.
I don't think that's correct.
No,
Okay.
Maybe in certain types of
I'm
studies.
just saying cardiology, it almost always correlates. There are exceptions, but it largely correlates. In cardiology at least, I can't speak to all the fields, but I can tell you, we're not going to see a randomized clinical trial done by the NIH. I've gone there 3 times with Phil Greenland and Don Lloyd-Jones and all the other people I quoted. They're not going to do it. it's too expensive, they don't want to, Gary Gibbons doesn't want to be in the trial business, Dave Marin used up all his money. There's a lot of reasons out there, but we've gone 3 times. We've proposed it 3 times to 3 groups, and they're just, they don't have the, it gets good scores, but they don't have the appetite to fund it because the size of the trial would be huge. The National Lung Cancer Screening Trial was 40,000 people, the MASS trial. You think you're gonna, well, there's other ways of doing it. It might be done in, right, so it might be done by smaller groups, but the big study that Phil Greenland tried to put together, which would cost somewhere in the order of $100 or $80 million, won't be done in that format. There are international studies being done that are randomizing people to calcium versus no calcium, so maybe those would be acceptable to the US Preventive Task Forces if they're well done. And certainly, they're being done in Europe, not in, so maybe acceptable, but there are some randomized trials being done. But I agree with you, Bob. I'm a scientist. I'd love to always say, let's do a randomized clinical trial. It's always at the top of the heap. I'd never dismiss that. But it may be hard to do, or it may not be fundable because the funding agencies may not have the appetite for it. It's also hard to randomize people who have coronary calcium to not get a statin. That might be unethical, at least in the United States. So the randomization may be challenging based on how you design the trial. I'm just saying that's come up in a few different forms as well.
Robin Okada.
Who's known you since college days, stand room years. I was wondering, why can't it piggyback on another study? Like another study that where introducing the calcium test wouldn't change the outcome of that study, but then you could collect the data. Would that be seems like that'd be a lot less
what the U.S.
expensive.
Preventive Task Forces would like, and the standard to get that one, the number 1, would be you get a randomized trial of you get a calcium score or you do not, and the group that got the calcium score lives longer, right? And as Dr. Adams pointed out, the problem is the treatment of coronary calcium may be multifactorial, like Dr. Sidney pointed out. It may not be as simple as mastectomy or lumpectomy or abdominal aortic aneurysm resection. That were, some of the cancer and other screening trials were successful because the treatment is very straightforward. It's only one option. We don't have just one option. As Hattie mentioned, there's a lot of guns in the holster and treatment may be very divergent.
Okay, we're near the magic hour here. I mean, this has been a great discussion. What I take away is it's not necessarily either or. It may be, it may not be practical, etc. Always good to have a plan B, right? And then also, I think what Doug was saying is, and what I'm hearing is, perhaps we're not yet at the tipping point of the observational studies, study after study, to the extent we were obviously now in smoking. Maybe you feel we are, Matt, or getting very close to it, but more observational. And I think in particular, Kaiser Permanente, there are increasingly in the United States now large integrated delivery systems with large population-based data, Intermountain, Virginia Mason, Geisinger, and others that are doing epidemiological scientific studies, etc., randomized trials as well as observational data that I think we need to take more advantage of in order to get to the tipping point, so to speak. So that's one takeaway that I see from all of this, and something that maybe we could encourage, here in the Bay Area. When we have these other systems like Sutter, etc. Dignity, another one. Down in Los Angeles, there's some down south as well, besides the UCLA health system. So I think this is good. And I also would say that, I don't know, Nirali, Ellen, if you want to make some comments as well before we take our break, but really what needs to occur is what's going to happen with people we need to influence outside this room in terms of primary care physicians and how they understand these kind of conflicting messages, etc. And then the patient community that come to you all and say, well, gee, what should I do? Or, and well, what is it that really matters to you? What is it about your life? Etc. Let me give you some information and data. It can be confusing, but let me try to simplify it for you. I don't know, Nirali, Ellen, you want to close out at all?
Yeah, I guess in the interest of time, we'll just wrap up now so that we can
You're the one. But I absolutely
And
agree.
dessert.
I absolutely agree. I think that thinking about what pragmatic trials and what kind of way we can use big data to help us move forward is one important point. And then the other aspect is, of course, what you mentioned, Steve, which is how do we get the message to the public that these two recommendations are not in conflict with each other and are actually addressing two different groups so that practically we can move forward. Because I do think that's a fair statement after everything I've heard today. I'm thinking, okay, in my cryptogenic stroke patients, 1 in 4 patients, maybe I should be doing coronary calcium scores on them. And that is another population for the comment of where maybe we can add in SDAC scoring and not feel like we have to randomize those patients to certain types of therapies. So in any case, I think we should continue this one-on-one discussion outside. I really thank you all for coming. Any other comments?
No, I just want to thank everybody. This has been very enlightening, and I am very excited about getting coronary calcium.
We're all very excited. All right, thank you everyone.
Thank you, Michelle, for helping us kick this off.
I see you guys. Yeah, you guys saw the red dagger? Yeah, we're gonna use I saw her once there.
Okay, she should be going. She should be going to on our behalf. I'll talk to Dr. Ivy about that as well. I'm assuming she's still going to do stuff, right?
Yeah, she does. But they've kind of evolved a bit. We're doing these presentations now.
I got to catch up on that.
Okay, nice to see you.
Oh, yeah.
Jeff put it on. Realizing. You live it up. Yeah, anyway, I wanted to say hi. It's been a long time. Nice to see you again.
I'll let Kevin know.
Okay. Yeah, Jeff.